Hello, everybody. Welcome back. So glad you decided to come back, even after the AHRQ Echo series. So I'm just going to give everybody just a couple more minutes. Okay, so shall we get started? All right, it's good to see everybody again. I'm gonna take a look at that list. Wow, good, all good familiar faces and names. Good to see you all. So we're just gonna start off with our introductory slides. So, as you know, this is our relaunch of the Long-Term Care Learning Action Network, where we can develop a community of learning, confidential case sharing, very practical advice for each of us, and figuring out how to support each other best through these challenging times, free CME and CEs. So yeah, so it's great. So as you know, type in your name and your facility as our way to keep track of attendance. Okay, and then these, of course, of all of our sponsors, the series is made possible through GWEP funding, through HRSA, as well as the support and partnership of HAH, Mountain Pacific, United Healthcare, and Aloha Care. Okay, next slide. And of course, we commit to maintain and safeguard confidentiality of information. All case presentations must be HIPAA compliant. And we're going to create a safe learning environment where we're going to just no negativity or blame or shame, just encouragement as best as we can. And of course, that case consultations do not create or otherwise establish provider-patient relationships. And this is entirely all educational. Next slide. And of course, we welcome you to share any cases or questions you may have in advance. But of course, we're happy to have you just share, just whatever pops into your head as well. That's fantastic as well. But if you do have questions in advance, you can go ahead and go to the website to get that form. Okay, this is our new schedule. We are now moving to 2 to 3 p.m. on the second Tuesdays of each month. And we're going to do a strategy of we're going to concentrate on one topic for a few months and then move on to the next topic for a few months. And so for the next few months, we're going to be doing depression. Today, we'll be doing recognizing depression, then moving on to SBAR for depression and medical treatment, talking about social isolation, and then behavioral activation. So lots of things to think about and share over the next few months. Next slide. Okay, so we've changed the format a little bit for this reboot of our long-term care echo. And so part of it, we're going to be talking, we're not just going to talk about dairy topics and age-friendly health systems. We're actually going to talk also about taking care of each other and well-being, making sure that we have strategies in place for that. And also to have some discussion about QI strategies for each of these topics that we cover. And then also will be, and that will be covered by Dana Mitchell, who's with Mountain Pacific. And then we're also going to be having Lori Henny from HAH, and she's going to be giving us regulatory guidance and updates about COVID each month that we meet. So yeah, next slide. This is just for CMEs, as you know. It'll go into the chat box actually towards the end of the session, and then you can just click on it and fill out the evaluation in order to get your CMEs. Next slide. And this is our hub team. So I'm the course director and speaker for today. Gail Rodriguez is the director of nursing at Oahu Care Facility, and she will help facilitate. And as I talked about before, Dana Mitchell, she will be our QI coach, and Lori Henning will talk about the COVID and regulatory updates. Okay, so without further ado, I'm going to pass it off to Gail. Oh, Gail, I can't hear you.
I know that a lot of us in our nursing homes have had a lot of staff, taking off because of COVID and their families. And our staffing sometimes is really difficult. So just want to give you time to maybe share some of what you've been doing at your facility. And I'll just give you an example. For our facility, we have a lot of staff that have been taken off, and I know that it's very hard. So we want to support them and support their families. So we did utilize the program where they were able to take off and they were paid through the federal grants. But now that that's not available, what are your facilities doing, and how are you supporting your staff and their well-being to care for their families? Does anybody else want to share? So if no one else wants to share, maybe we should just go ahead and continue. Unless you want to write it in your chat, maybe some of you can just chat in some of the things you've been doing at your facility or your staff, and what you've been doing for your well-being on your behalf.
I kind of have a comment. This is Dana with Mountain Pacific. As y'all might or might not know, I live in Anchorage, Alaska, and I thought I had heard somewhere several months ago that Hawaii was getting some FEMA or Red Cross nurses or something, but Alaska just got 500 because we're doing really, really bad with cases and staffing. All of our hospitals are on crisis standards of care. And I talked to one nursing home who was really happy to have gotten some and was able to give some of her staff some time off for the first time in months. And that's not something that's under like your control as an individual home, which is why I just shared it as a comment. I just am seeing tiny slivers of hope occasionally.
Yeah, so Dana, we did have some of those nurses that came originally in the beginning, and some of them did come to long-term care, but the ones that we received recently, they went strictly to the hospitals here. So that was really good on their part to get it, but we had gotten help earlier on through the help of HAH, and they provided a lot of nurses for us, some strike nurses, to help with infection control and so on and so forth. So that was very good and very
big help.
Yeah. Anyone else wants to share? Right, I guess maybe we should move forward.
So if, of course, we still welcome your thoughts and ideas, and we can talk about them a little later. So if you have thoughts, please type them into the chat box, and we'll be sure to comment on them. All right, we're gonna just now move on about talking about recognizing depression, right? Oh, don't you love ER? All right, next slide. Okay, so before COVID, up to 30% of nursing home residents had minor or major depression. That's kind of the baseline going rate, right? And although depression can be improved with therapy, they often go unnoticed and untreated. And, depression results in lower quality of life, poor functioning, more hospital rates, and premature mortality. And so that kind of was what life was just before COVID. Those were the prevalence rates, as you can see in this article in 2019. Next slide. But as you know, once COVID hit, we had a lot of social isolation, physical distancing, and social distancing implemented. And, loneliness is different from depression, but it's similar and it does impact it. So I just thought it was really important to just bring that up. So loneliness is also common in long-term care institutions. And the prevalence of severe loneliness in care homes is at least double that of those living in community settings. And this is just a study from that. 22 to 42% of care homes compared to 10% in the community dwellers. So I would imagine nursing homes are probably in that range as well. And there are activities that decrease loneliness that we can consider implementing. But loneliness, if it kind of goes unchecked, can increase the risk for depression, suicidal thoughts, aggressive behaviors, anxiety, impulsivity, and cognitive decline. Next slide. Next slide. Okay, yeah, oops. Yeah, so, no, what happened to that? Yeah, that's the right slide. Oops. Okay, this is the right slide. Yeah, so I just wanted to point out that social isolation is different from loneliness and it's different from depression. But social isolation is really defined by the level and frequency of social contacts. And not everyone who's socially isolated is lonely. There are people who are introverts or hermits, and they like being socially isolated, and they're not lonely at all. They're quite happy, actually. And so it's not necessarily leading to anything, but it can often cause loneliness. And what loneliness is a feeling from the lack of meaningful relationships. It's a feeling that people get that may worsen because of social isolation. And stemming from loneliness is depression. And what depression is, it's a clinical diagnosis, which, has to be determined by, the clinical criteria. And so those are just some of the differentiating points. Next slide. Okay, so there was a so they were trying to figure out, well, there's got to be an impact of COVID-19 on well-being. So somebody actually did this huge study. They looked at a study of long-stay residents in Connecticut, and it was, 29,000 people of all the nursing home residents in Connecticut, and they all did the MDS assessments. And they compared it between March and July in 2020 and compared it to the same period, March and July in 2017, 18, and 19. And what they found is that the prevalence of depression increased quite significantly, as they also saw substantial weight loss, which we're all not surprised by, because, yeah, we've seen that too. Maybe due to depression, but also maybe due to decreased feeding assistance and all these other things. But yes, these are the two top impacts that they've seen as an impact from COVID. Next slide. But we also know that depression can sometimes be very hard to see, right? We look at people, we're not really depressed, they just have dementia, or maybe they're not complaining of depression. In fact, they'll tell you they're not depressed, right? Some symptoms, like they're just having more aches and pains or somatic complaints of dizziness or something else or other. These are all somatic things. Or they just might be a little bit grumpy, or they may be seen as getting just old. But older adults typically do not complain of sadness. And that's what makes it hard to detect. Next slide. So we have to think about this a little bit more. We have to think about how do we recognize people with depression, right? So so let's think about it. Do we know, these are the different clues that we might find, right? Do you know any residents who have stopped eating or losing weight? Certainly it could be due to other things, but that's something to consider. Or does the resident tell you that they're too tired, or they just don't want to get out of bed for activities? They just want to stay in bed now. They used to be sharp and now have trouble thinking. Do they cry more often than before? Those are just some thoughts. Next. Or do you have, residents that say, I'm no good anymore. I'm useless. Or I want to die already, Or do they say sorry all the time, even though there's really nothing to be sorry about? Or is your resident just grumpy? Or are they just having more challenging behaviors? Sometimes having challenging behaviors is a sign of depression. Next slide. So we have to look out for these signs and symptoms. And these are some of the items from the PHQ-9, which you should be able to recognize, noticing that there's sleeping changes, whether they're sleeping all the time or not enough, loss of interest in doing things, feeling worthless, having low energy, or having more trouble thinking or concentrating than before, loss of appetite, moving more slowly, called psychomotor retardation, more anxious or agitated, or even talking about death, not necessarily suicide. They might, they may just talk about, I wish I was dead. But that should not be ignored, because I've certainly seen suicides in nursing homes as well. That does happen. And it's also really important to note, because depression causes a lot of other symptoms, not just sadness. So if we're all looking for sadness and crying, we may not pick it up at all. And it's also important to ask, because you can see all of these different signs and symptoms. We should ask others around us, other colleagues and other family members or whoever, if they've noticed any changes. Okay, next slide. So that comes to the next part. How do we assess loneliness and depression? Next. Okay, so loneliness is a reflection of how connected to others and how supported we feel by others. So this is not an MDS assessment. This is from the UCLA loneliness scale. There's actually a lot more items on there, but I just picked out a few of these. So just to take a look at, do you have any residents that have been admitted and they actually have nobody to talk to? Do they talk to anybody at all? Or do they feel like nobody understands them? And they tell you that too. They say, oh yeah, no, I can't talk to anybody here. Nobody understands me. Or they're no longer close to anyone. They've lost all their social connections. Or they used to have these hobbies and interests that they can't do anymore, no longer available to them, and they're not shared by the people around them. They can't even talk about it, right? Because nobody gets it. Or they're unable to reach out and communicate to those around me. I definitely see that, right? Especially when you have people with some with dementia, some who are cognitively intact, and they're all mixed up together in one unit and they can't talk to each other. Or it's difficult for me to make friends, or nobody knows me really well. I think we can spot some of these people on our units and know that these are the risk factors for getting depressed. So it's important to recognize this in advance and then maybe even be able to intervene before they get depressed. Next slide. And then what about depression? So once we start seeing the signs and symptoms of depression, we should really think about doing that PHQ-9 form, right? So that's MDS section 3, MDS 3 is a section D, right? And before doing that part, right, if you remember, there's the section here that we have to assess whether or not they're able to make themselves understood or not. And so if they're not able to make themselves understood, then we skip ahead to section 0500, which is the staff assessment of mood. So it's the PHQ-9 observation. That's the OB. And then you kind of check off that box and move ahead. Next slide. And if the resident cannot answer the questions, then we have to ask the staff, right? Turns out about a third of long stay residents cannot answer the PHQ-9, and so it's up to the staff to help with that. And then the residents, it's important to interview staff from all shifts who know the resident best, not just one staff, you know, and make sure to ask the staff in a private location, not in the middle of the hallway, to announce it to everybody. And of course, recording the presence and the absence of symptoms. And it's important to really think about all of these factors as we think about their care plan as well. Next slide. Okay, and if they can make themselves understood, we really should try our best to ask the resident directly, and then complete the section, the mood interview, you know, and really try to, because, you know, talking about depression is kind of a sensitive thing to talk about. So really try to set the scene up, ideally sitting at eye level position with good lighting, eliminating distractions, you know, having a cue card on hand will help the resident more easily quantify the frequency, because it's a lot of items to keep in your brain as you ask the questions, and I'll just show you that a little later. Maybe take his or her hand to show you're supportive and encouraging them, and also speaking clearly and loudly. Next slide. So that's the PHQ-9. This is the resident mood interview section. And the important thing is that we have to talk about over the last 2 weeks. It's over 2 weeks, have you been bothered by the following problems? And the first thing item is in column 1 is whether there's a presence of these symptoms, such as, you know, little interest or pleasure in doing things, feeling down or depressed or hopeless, trouble falling asleep or staying asleep or sleeping too much, et cetera, et cetera. And so if it's no, then you enter a 0 there, right? And then you enter a 0 in the next column too, because there's no frequency if it didn't even occur, right? So that's the presence of the symptoms. Next slide. Right, so yeah, coding the symptoms, and then if you code a yes, then of course you move on to column 2 and you code the frequency. And then if there's no response and they don't answer you, then you leave it blank and you code it 9. Next slide. Okay, and then this one is symptom frequency, which is column 2. And so the question is, over the last 2 weeks, how often have you been bothered by these symptoms that are listed here? So it's either never or 1 day over the last 2 weeks, or several days in the last 2 weeks, 7 to 11 days, which is more than half the days, or nearly every day. Next slide. Okay, and then, you know, showing a cue card might help with that. So the next slide shows a cue card where you can ask them and show this at the side while you're asking, because then that can help them identify how much it bothered them in the last 14 days. Next slide. Okay, and then after you finish doing that, then you take your calculator, right? And you add up the scores for the frequency of responses in column 2. And then that gives you your PHQ-9 score. Next slide. And then there's this little safety question down at the bottom underneath that, 0650. If a resident says, I want to hurt myself, and you know that they have a way to do it, then you have to report this right away. This is a suicide risk. And so you have to monitor them more closely and call the physician probably. Next slide. Okay, these are the different levels of depression, a PHQ-9 score of 0 to 9. If they have that and they do not admit to depression or suicidal thoughts, then it's probably mild depression. If their score is between 10 to 14, or they admit to depression or suicidal thoughts, they're under moderate. And if their score is 15 or higher, they're considered to have major depression. Next slide. And I think the most important thing, the big takeaway here is we have to notice it. If we don't notice it, there's nothing we're going to be able to do. We're not going to be care planning for it or anything like that. So that's where I wanted to make sure we all do. Just pay extra special attention because there is a higher prevalence right now than there was before the pandemic. Okay, so I'm going to open it up to questions. If you have any questions, and then maybe Dana, if you want to, any questions? Comments? What have you guys been seeing? Have you been seeing more depression?
I know, every home that we speak to is very concerned about loneliness. And I think that feeds into the depression. I haven't had so many people mention depression specifically, but loneliness is a huge concern for everybody. And I think, the administrators and DONs are getting tired of having to keep people isolated and away from their loved ones. And I'm sure that manifests as depression. And also I'd say that in just my personal life, I think people my husband calls it COVID crazy. I think I'm seeing it a lot, just in general.
Okay. All right. So Dana, do you want to go ahead and talk about QI?
Sure. So go ahead and go to the next slide there, please. Since Aida was going to talk a bit about depression and how you assess it and code it, I want to do a road trip right now so bad, and I'll even go with an alpaca. And so you might remember this from Brian Bjorn's slides at some point in the past year or so. But it's the point is kind of the emphasis that it's always a journey. Quality improvement is, quality is not necessarily a destination. It's the trip, it's the journey. And so this will feed, I think, really well into what Aida just spoke about. I thought I would talk to you about the QMs, just to get us kind of kicked off, because there is a QM about depression, so it fed beautifully into this topic. So can I have the next slide? Thanks. So Mountain Pacific shamelessly stole these quality measure tip sheets from another QIO, with their permission, actually. And we have these available. I didn't see them on our website. They're supposed to be there, so I'll make sure they get there, but you will get a copy of this one. And so we have these for all of the quality measures that feed into your 5-star. And so I pulled out the depression one. And Aida, Dr. Wen did a nice job of going over the coding for depression. So here is the overview of the QMs, and I'm sure you all know it pulls from your MDS. So this measure is going to take a look at the percentage of your long stay residents who have symptoms of depression during that 2-week period on your assessment. And so, it takes the resident or staff interview, just like she showed, and your PHQ-9, and then it'll trigger if the resident meets one of these 2 conditions. So the first one is the resident mood interview must meet both these parts, part 1 and part 2. So part 1 is the little interest or pleasure for half or more of the dates of the last 2 weeks, or feeling down, depressed, or hopeless half or more of the days of the week. So it's taking a look at those assessment pieces. And their total severity score indicates the presence of depression. So that score that feeds into the PHQ-9, or comes from, I guess. Then the second condition that could meet the trigger is just the staff assessment piece, if you're coding for that. And it's the little interest or pleasure in doing things half or more of the days, or feeling hopeless, or peering down, depressed, or hopeless half or more of the days. And then the staff assessment also indicates the presence of depression. And so she went over the coding. So I don't think I probably need to go over that, but let me show you the denominator. I have all your faces over my denominator. So your numerator are the residents that trigger for depression. Your denominator are all of your residents, excluding those who are comatose or your comatose status is missing. And if they're not included in the numerator. So the folks that are triggering are not included in your denominator. It's the rest of your staff with those exclusions. So next slide. So if you're getting your QM reports, your Casper reports, and you're showing that you're triggering, or you're pulling your 802s and you're showing that you've got residents that are triggering, I'm gonna just interject real quick because when, I don't know if you know, Lisa Johnson was working with our Alaska QIO representative in the past, and she would send us our own rates plus the state of Alaska states, and then I think she would send the comparing with our region, which is Montana, Wyoming, Alaska, and Hawaii. And Hawaii was always the highest on depression. And we're like, well, no doubt, we're dark all the time, and you guys are out there in the sun. I'm sure it's way more complicated than that, but we'd always say that's just not fair. But so if you've got folks that are triggering, these are things that you could consider if you wanted to address that measure. So always look and make sure that your MDS is coded appropriately. And are you timing that interview according to the resident's behavior patterns, so person-centered approach. If they're normally in a bad mood in the morning, did you do your interview right when they're in a bad mood? Or did you catch them, are you catching them after, I don't know, a medical procedure or something that's making them anxious or, anything like that? You might want to take a look at when you're doing those interviews. Are all of these uncomfortable issues being managed? Are they hungry, thirsty, bored? Are they in pain? Are they dealing with any adjustment issues? Right now, of course, the resident's family being involved and supportive is our big challenge. Are they being involved in their care? Are they being able to make decisions and choices related to their preferences? Spiritual needs and religious preferences, are those being met? This, I think we struggled with in the homes that I was in, which was developing activities based on residents' individual needs and preferences. We had I was there for about 9 years, and over the course of that, there was a huge shift in the demographic of the residents that were coming into the transitional care side. They were getting younger and younger, but we were still doing activities based on an older kind of generation's preferences. So getting those resident-centered is really important. Are we incorporating their cultural or ethnic traditions, hobbies and interests, and whatever they like and don't like? Then do they understand their disease, their condition, why they're even there? Are we able to provide psychological services? And are you monitoring behaviors? So is there a behavior tracking process in place? I think one that I think might be overlooked more than it should be is sleep patterns. Are we tracking how they sleep and how are we supporting them to sleep? I think that's crucial. And I don't think we did a great job of actually keeping that monitoring in place. In addition to adverse effects of medications, are we monitoring those as well? And I know that can often be very challenging, but if you're wanting to really take a look at your depression scores on your QMs, I think these are some great tips for how to assess those and address them according to your residents' individual needs. That was kind of a lot, but you'll get this, so you can hang on to it, print it out and hang on to it. And we can keep them coming if you like them.
Thank you. Yeah, so I'm just gonna open it up again and see if people have any thoughts or comments, any challenges that you're facing with regards to doing assessments for depression. Probably I'm just thinking, maybe maybe not as much time to take to do that, maybe. Anybody finding that to be a barrier?
Hey, it's Maria. Can you guys hear me?
Yes.
I'll just tell you a funny story. When you were going through that questionnaire for depression, when we had to stand up our COVID unit, you know, we limited people going in and out, right? So the social workers were not allowed in, just the nursing staff were, you know, the essential personnel. So they needed one of those depression scales done. And so I had never done one before, so I wasn't really well prepared. And so, you know, they just kind of said, here, ask these questions and mark the boxes. And I was like, oh, okay, that sounds easy enough. And it kind of took me by surprise when you get to that last question about, hey, have you ever thought about suicide? You know, and I don't think I was very graceful in how I asked it, because all of a sudden, you know, I'm just like saying, you know, do you want to kill it? I would have appreciated this conversation before I had to go in and do that screening, because I was like totally, I wasn't prepared to, you know, suddenly, you know, walk in on this stranger and just say, you know, have you ever thought about killing yourself? And it was just really awkward, I thought. So now I know. That's probably good for our, because it's usually our social workers that do the screenings, you know, not the nurses. So to just kind of read the questions and check boxes probably wasn't as effective had somebody with better training and maybe even a relationship with this person, you know, done it. But it was just, you know, needed to be done. So, hey, here I go. And man, that was pretty awkward.
Yeah, actually, yeah, I hadn't quite thought of it that way, the disruption of completing the MDS, right? It's just not done the way it's usually done now. How are other people doing it?
So, hi, this is Gail, and we don't, normally the nurses don't do it, but I do know that we do get trained to fill out that form. And so it's really good to review it with the nurses like at least once a year. I think that's a good way of, you know, getting help if your social worker is not feeling well and it needs to get done, because I know that the MDS person takes on a lot of responsibilities. So if you could help them, that's a good one to do, actually, the PHQ-9. And you get to know your patient a whole lot better, you know, as a nurse, because now you're, you know, you're looking more into psychosocial and mood, and if they're able to respond and you don't have to interview the staff member, you know, it's kind of good to interview a resident. Because I had an opportunity to interview my mom. So that was quite an experience, and it opened up a lot of ideas. Yeah. Anyone else want to share?
You know, I wanted to comment on that this whole thing reminds me of the whole intent of the MDS. I think we've lost track of what the whole point was, right? Because now it's just a form that you fill out that you got to submit to CMS, right? But what the point of it was to be able to do geriatric assessments and to actually recognize depression, you know. But if the frontline staff and the nursing staff aren't doing those assessments, they don't know their residents, they don't know these problems, and only an MDS nurse knows about it. You know, that defeats the whole point, I think, of the MDS, because the person who does them is also should be part of, you know, thinking about how do we get them out of this? How do we make life better? How do we make them less lonely? How do we address all these various things? So I'd like to see if any social workers want to comment on this or other DONs.
So I'm not
So-
sure who made this comment, but they said, I think it's important to set the stage before issuing the GDS, saying that I will ask you some questions to check on your emotional well-being. So do you want to share? This is Jacqueline. Would you like to share some of your experiences? Are you able to? Because I'm not sure. if
Can you
we
hear me?
unmute.
Yes.
Yeah.
Oh, okay, good, good. Hi.
Hi.
I guess it's easier to speak rather than type. Yeah, I feel I've done a few GDS and of course the MDS Section D I have to do on a regular basis. I believe it's very important you prepare the person before you actually ask the question so that they won't be so surprised with the type of questions you ask. And oftentimes when I do the GDS, I will tell them, yes, to not make it like, oh, I want to check whether you're depressed, but to set the stage, we want to check on your well-being, because the well-being is more than physical, it's also emotional and psychological. So we just want to see how you're doing in that area. And by asking and also stating that because this is an instrument I'm using, I'm going to have to use the exact words that's listed on the question. And if you don't quite understand, what the question means, then I can, perhaps paraphrase it or explain it better. And I think if you set the stage, then the person won't be so surprised by the type of questions you ask.
Spoken from a true social worker and the mouth of experience. Thank you, Jacqueline.
You're welcome.
Great.
Uh,
I was just going to say, I used to, do the same thing, administer the PHQ-9 and the GDS. And I completely agree with Jacqueline to set the stage, to set it up. And just, a minute of explanation can make a world of difference and also put that individual at ease, because sometimes it can be difficult to talk about and to think about these things. But, especially that last question can be a little bit of a shock to the person administering it. Just as Maria said, that it's very blunt. And I used to train other social workers to do this, but I told them, my experience is that is a blunt question, but for those individuals that are in that place and they are thinking about suicide and how they would do it, or maybe they already have their plan in place, what I found was that those individuals actually appreciated the question being asked because people don't talk about that. And that they were very straightforward to say, yes, I have thought about it. Thank you for asking me. And they'd be willing to share more about that process because it's not something that comes up in everyday conversation. So, one of those things, again, is just people are willing to share and they want someone to reach out to them. They want to have that opportunity. They are feeling isolated and lonely. So just by that very nature of the question, initially, it might be hard for us to ask that, but we really are crossing that divide and reaching someone who needs an opportunity to express themselves.
I'd like to, this is Jackie speaking again. I'd like to speak to that chat question about how do you deal with a stoic person who doesn't want to share. I think emotional well-being is a lot harder to assess than physical well-being. It's not like, okay, you see the leg is swollen and you can ask the patient, how do you feel? Emotional well-being is really voluntary. And, if the person does not feel comfortable sharing with you, we certainly have to respect their rights not to. It may mean that they don't feel comfortable with you. It may mean that you have to keep going back so that the person get to know you and start feeling comfortable with you to tell you their inner thoughts. It's not easy, and not everybody's created equal. Some people are very vocal about their feelings. Other people are very shy about it. And it just, I think we have to really treat each person individually and approach them differently.
Yeah. I'll just reiterate the point that a lot of older, it's kind of, embarrassing or a little bit shameful to admit that you have this weakness. So a lot of folks, older folks, don't want to talk about it or admit it. So that's why we have to recognize the other signs and symptoms.
I really appreciate the folks who are used to doing these for speaking up and sharing your experiences and the best tips. Thank you so much.
So Denise, I was wondering, what is your tip? Do you have one for putting people at ease? Oh, okay, sorry. Do other people have tips for putting people at ease, having this conversation? Or have you, are you guys in the habit of pulling together the team and talking to the CNAs and pulling all the observations together to do the observation, the PHQ-9 observation? How do you guys do that nowadays with the COVID units and such? Hmm. Yes. We reflect off that, yeah. The less anxious I am, the less anxious the assessment comes off. Yeah, actually, yeah, you could practice doing it with a colleague. So what do people think? Is this something that you feel like you should train all your staff to do? Even if they're not filling out the PHQ-9?
I don't know if folks are familiar with the stop and watch. I don't know if anybody uses that, but I think this, you know, when you ask, could you train everybody to do it? To me, I think having everybody just be dialed into any change in a resident, and, you know, that should be all staff, and it should include depression symptoms, or, you know, if they say if somebody's not acting right, depression certainly could be considered or taken into consideration. But if we can get everyone to understand and have a respect for what may seem like a small change to them might mean, and just be on the lookout or aware, you know, eyes peeled for those kinds of things, depression, I think, would come out in those as well.
Great point. Great. Any more comments? It's good discussion. I'm glad that we're wrestling with this a little bit and thinking more deeply about how we assess our residents. I was wondering, you could keep thinking about it and you can chat in the box still, but I'm gonna hand this off to Lori Henning to talk a little bit about what's been happening with COVID here these days. Thanks, Lori.
Okay, so I am going to attempt to share my screen with you. Just have a few slides. That up for you?
Mm-hmm. Got it.
Okay, so I just wanted to share, you know, some of the data points for you so we can take another look at where we're at with COVID-19. And so the next 4 slides that you'll see come from Laulima Data Alliance. So all of our hospitals in the state of Hawaii are reporting COVID-19 statistics and data to Laulima, and then they are then producing, you know, some of this data and slides, sharing it with various stakeholder groups, and of course the Department of Health. So on this slide, you will see a graph, and it shows the number of new COVID-19 cases per month throughout the pandemic, and it's broken up by island. So Honolulu County is the light blue line at the top, Maui is green, Hawaii County is red, and Kauai County is the darker blue at the bottom. And the time period for this is April 1 of 2020 through October 8th, 2021, so last week. And you can see some projections there at the right for where they're projecting that we're headed out to in the next couple of weeks. So as you know, we are trending down from our Delta surge, and that is a positive sign. So let me go through and show you a couple other things. So this slide shows for the entire state of Hawaii, this is the total confirmed COVID-19 patients hospitalized in-house per day. So again, you can see that our recent peak was in early September. And again, we've been on the trend downwards since then. And our total COVID patients in ICU, this is for the entire state of Hawaii, has also decreased dramatically from early September. So again, as we take a look over the last year at our journey, we're on the right track right now. And then this slide shows, this is again for the entire state, the total new COVID-19 hospital admissions per day. And again, trending downward. Now these slides come from the CDC. And so you can see that this is last week's data. They produce this on a weekly basis. So for the week of October 3rd through October 9th of last week, Hawaii had the second lowest infection rate in the nation. And that is down from being the fourth lowest the prior week. So again, we're doing well. And then this is for the entire duration of the pandemic. And they define that as March 7th, 2020 through October 9th, 2021, because this is through last week's data. Hawaii has had the second lowest infection rate in the nation. And as far as death rate, again, this is just looking at the week of October 3rd through October 9th of 2021. Hawaii had the 19th lowest death rate in the nation. And that was down from being ranked at number 29, the 29th lowest spot the prior week. So again, we continually reduce. And so overall, for the entire duration of the pandemic, again, they're talking March 7th, 2020, and this data goes through October 9th, 2021. Hawaii has had the second lowest death rate in the nation. So just wanted to share those statistics with you. And as we've all seen, you know, our facilities have done such tremendous work and just really been in tune to infection prevention and control and watching to ensure, you know, with COVID-19, trying to keep it out of our healthcare facilities, and when it does come in, to really respond to it quickly and decisively. And really, Hawaii has done a fantastic job throughout this pandemic, keeping this, and you can see it as where we're ranking with the rest of the nation. I'm gonna hand that back to you, Dr. Nguyen.
Okay, thanks so much. It's always good to get good news. Oh, so Maria asked, any idea when COVID tracker will be up to date? I don't know. Do you know, Lori?
I don't know. Let me look at that real quick. I'm looking at which COVID tracker. Is this the one from DOH?
The one that we have to check our positivity and transmission levels every week or 2 weeks or whatever. It's a CDC one, because they said it was down yesterday for the holiday, but it's usually updated by now, because I usually send out data every week and I can't get last week's data.
That's right. So yeah, and so yes, you're absolutely right, Maria. So we recently changed this week, right? Monday this week. So we are now tracking based off of the community transmission rate instead of the county positivity rate. And yeah, that website, I can put it in and check real quick to see if I can get anything now. But I can also copy paste that link in the chat. I don't know when that data is going to be updated. That we should have.
Yeah.
But right now, according to what we at HAH have seen, all counties in Hawaii are in the red zone for community transmission rate. And so that means that, you know, currently we are to be testing any unvaccinated employees twice a week.
Thank you.
Yeah, it's kind of a challenge, and I'm wondering when CMS is going to come out, if they're going to come out with different visitation, right? Because they're saying, hey, you have to allow indoor visits if your positivity's less than 10%, and now all our positivities are good, right? Like most of them, almost all of them, except maybe Big Island, are below 5%, you know, but the transmission level is still high. So it's kind of hard to know what's safe to do, and you know, because we've only been limiting our visitation to outdoors, you know, since we had the spike. But now that everything's coming down, I feel like we're going to have to start allowing indoor visits, and yet our transmission levels are still considered high. Though I think a couple might go substantial this week. That's why I'm kind of waiting to see if there's progress. But that's still twice a week testing too, you know, so
Right.
tiresome.
Yeah, I guess HAH will update us, right, as they find out. Thank you.
Yeah, as of yet, we've not heard of any updated guidance coming out from CMS yet on visitation guidelines. And that question has definitely been asked as well as by the American Healthcare Association, is in talks with CMS quite regularly on what's happening and updates and everything. And they have not heard anything yet, but it doesn't mean it to say it's not going to come out. I'm sure we will hear something.
Great. All right, so it's 3 o'clock now, and we've had a really great discussion. Thank you so much, everybody. We have in the chat box, Michaela put in a reminder about evaluations. So just click on the link and complete the evaluation, and that'll be great. And of course, you know, let us know if there's stuff that we can do better or how we can improve the session. But we really enjoy having everybody's input and sharing, because it makes the discussion much richer and we can learn from each other. So thanks so much, everybody. Thanks, Gail. Thanks, Lori.
Thank you.